Welcome everyone. My name is Ann Clark and I'm with Senior Health Partners. I am also part of the leadership team for Miles for Memories and have been involved since the inception. And tonight I get the distinct pleasure of welcoming two very important people to our community. We have had the pleasure for 10 years plus now to welcome Dr. Scott Counts and Dr. Graham Atkin to our community. They don't just come and present tonight, but they are always at our beck and call in some cases to assist us with very complex questions, and they really provide us with directions on where to go. Well, not where to go, but where to go for help.
Right here.
Yeah. Dr. Scott Counts is an associate professor of transitional neuroscience at Michigan State University College of Human Medicine. He is our researcher, so the research type questions or any new research that we see that comes out, I typically send it to him and say, hey, have you heard of this and what do you think? And Dr. Graham Atkin, who is an associate professor at MSU School of Medicine. Graham was originally our first researcher who was awarded some funds through Miles for Memories. He then transitioned over to education, where he is teaching the future doctors of what they do and don't want to be when it comes to medicine. He has brought over 80 plus students to our area to have people such as yourself really educate them about what they've went through with their diagnosis, how they've been treated, because it's important that we understand that we are not our diagnosis. We are a person with a diagnosis, and we as people matter. So Graham, at this time, I'll let you introduce your students, because he also brought very important guests.
Thank you so much.
Thank you.
Thank you so much, Ann. Thank you, everyone, for being here. It is always such a tremendous pleasure to be able to come out to Battle Creek. I believe it's been about 9 years that I've been coming as a representative of MSU, and that relationship between Battle Creek and MSU is really important to me. And it sort of works in two directions. One is we're happy to come and answer questions and try to educate about dementia and things about the brain. But also, many of our students, as you've heard, over 80 of our students have benefited from being taught by the great people of Battle Creek about how to be better doctors. And that's actually part of what's going to happen tonight. So I have brought for you 3 students who are giving their first ever public talks to you about matters about the brain. Now, the brain, as you know, is the most complicated thing in medicine. So I'm sure they're very nervous. I still get nervous. I've been doing this for 9 years up here with you. But if you've ever been to the doctor and had that doctor do a bad job of explaining something, that's because they didn't practice it. They didn't have those kinds of experiences. We're going to change that for these students tonight so that when they get to be doctors, they are really good at explaining stuff. And that starts here tonight. So I'm going to invite them up. Each is going to talk for about 10 minutes on a different topic. And then Dr. Counts is going to come up and talk, and then I'm going to talk for a little bit, and then we'll open it up to questions and feedback. But if you would do me the favor of giving a very warm welcome to our first student, who hails from Chicago by way of East Lansing to us now. This is our second-year medical student, Yasmin, who's going to talk to you about dementia subtypes.
My name is Yasmin Rasuli, and I'm a second-year medical student at Michigan State University's College of Osteopathic Medicine. Growing up, when I would visit my grandfather in Iran, I always loved following him to the clinic as he took care of patients in the most empathetic and inspirational way. And I absolutely loved how he could make the most intellectually complicated diagnoses sound so simple, both for his patients and even for me. So the summer before high school, when he asked me twice in 10 minutes what grade I was in, I immediately knew that something wasn't right. That was the year that he was diagnosed with Alzheimer's disease. Being by his side all those years, I watched as he slowly lost pieces of himself, as he one by one forgot our names, eventually even forgetting my grandmother's name, his partner of almost 50 years. Those are the moments that weighed on me and continue to weigh on me to this day. But that's also the reason why I'm here today. I'm here because I have a sense of responsibility to learn as much as I can to help people in similar situations. I want to help ease the pain of patients and loved ones who are faced with a diagnosis that strips a person of their autonomy and their identity. More and more people are living with dementia worldwide. Millions of families across the planet are dealing with Alzheimer's disease, including my own. According to the Alzheimer's Association, 7 million Americans are currently living with dementia, and that number is reported to double by 2060. But what do we really mean when we say dementia? Well, dementia is the progressive decline in cognitive function. This includes thinking clearly, remembering things, managing emotions, language, attention, and social cognition. But not all dementias are the same. So we're going to go through different dementia disorders, their clinical features, their progression, and a little bit of the cellular components. But just so you guys know, the cellular components can be really complex, and not even we fully understand what's going on. In general, it seems like things are accumulating in parts of the brain that shouldn't be. So let's start with Alzheimer's disease, which is the most common cause of dementia worldwide, accounting for 60 to 80% of cases. So what does it look like? Well, Alzheimer's is progressive. Begins with difficulty remembering recent conversations, names, or events, depression, communication problems, eventually leading to confusion, poor judgment and behavioral change, wandering and getting lost, eventually requiring help with regular daily tasks, and ultimately, Alzheimer's disease is fatal, with a prognosis of up to 8 years after initial diagnosis. But what's going on in the brain? Well, what's going on is there seems to be a problem with the temporal lobe and the parietal lobe, which are both important for thinking, language, and memory. What seems to be the hallmark of Alzheimer's as we know today is that beta amyloid and tau tangles build up in the brain, which are bad and they're not supposed to do that. This leads to activating the inflammatory cells of the brain called microglia, which then have trouble clearing all of these bad proteins. This leads eventually to nerve damage, and eventually down the line, the brain starts to shrink. There's a lot we don't know about Alzheimer's, but we're learning a little bit more and more each day. Next, we have vascular dementia, which is the second most common cause of dementia, and it's also known as post-stroke dementia. Common risk factors include high blood pressure, diabetes, high cholesterol, and atrial fibrillation. The clinical manifestation of this disease can be really broad and really depends on what part of the brain the stroke happens in as to how it's going to present. This could make it difficult to initially diagnose just because it could honestly look like anything. Some important things to note, though, are that vascular dementia can coexist with Alzheimer's disease, and there's been a rise in cases since COVID. What's unique to vascular dementia is that the disease progresses in a stair-step decline. It progresses with plateaus, or the time in between strokes, and periods of rapid deterioration, or the strokes themselves, leading to the pattern that you see here. It's important to note, though, that this is just an illustration, and the stair steps will be different sizes depending on the stroke. Vascular dementia is different from Alzheimer's disease in that vascular dementia progresses a lot slower and it's treatable. Because we know that it's a stroke-based dementia, treatment is aimed at reducing your risk of stroke. So doing things like using blood thinners or cholesterol meds. Next, we have Parkinson's disease dementia. Parkinson's disease alone is a disease of aging seen in 2% of older adults. Parkinson's disease dementia, or PDD, is a later manifestation of the disease that presents in about 1 in 3 patients with Parkinson's. Parkinson's is a movement disorder that's characterized by loss of dopamine in the part of the brain that's necessary for movement, called the substantia nigra. When dopamine is lost, that's what leads to the movement problems we see in Parkinson's. So, Parkinson's disease is a movement disorder first and a dementia disorder second. Symptoms that we can see with Parkinson's include slow movements or bradykinesia, a Parkinsonian or shuffling gait, rigidity, face masking or simply an expressionless face, tremors, slow reaction time, and frequent falls. Dementia is a later manifestation of the disease, appearing around 4 years after initial diagnosis. Next, we have dementia with Lewy bodies, or DLB, which presents with both Alzheimer's and Parkinsonian features and is 5% of all dementia cases. We know even less about this disease than all the other ones, and the fact that it presents so similarly to the other ones makes it even more difficult to diagnose. What's a hallmark of this disease is something called Lewy bodies, which are clumps of the protein called alpha-synuclein that build up in the brain. When we see these, that's diagnostic for DLB. However, alpha-synuclein's also been seen in Parkinson's disease, which again makes diagnosing this even more difficult. DLB can present alone, but a lot of times it also presents with Alzheimer's. Well, how does it look? Like Alzheimer's, it presents with memory loss and confusion, and like Parkinson's, it presents with movement problems like stiffness and tremors. But the key difference here is that 80% of patients will present with complex visual hallucinations. Next, and finally, we have frontotemporal dementia, or FTD. But as the name suggests, it is a problem with neuronal nerve degeneration in the frontal part of the brain, which is seen in blue, and the temporal part of the brain, which is seen in yellow, or both. This is also the most common cause of dementia in people under the age of 65. What's happening cellularly here is that there's an accumulation of a variety of proteins called PIC bodies in those areas of the brain, leading to problems. FTD is unique in that it is a behavioral and language disorder, and it has a bunch of different subtypes of its own. But overall, it can present with changes in personality and social behavior, loss of inhibition and compulsive behavior, loss of executive function and decision-making, difficulty understanding or producing speech, and less so, memory. So clearly, dementia disorders are more than just forgetting things over time. It's imperative that we look for early warning signs and understand the differences so that we can diagnose them earlier, lead to proactive management, and potentially even slow down the disease process. Like I said before, sitting by my grandpa all those years is why I'm here today. He's the reason why I chose to become a doctor, and he's the reason why I'm here right now in front of you all. It's because I have a sense of responsibility to help people in similar situations. It's because I want to help patients and their families in the way that my family wasn't. I want to be a doctor that listens to patients and their loved ones, provides hope, and can hold your hand through the storm. To that point, dementia is a complicated puzzle that requires a team effort. That team includes your primary care provider, your neurologist, your physical therapist, social services, medications, and caregivers all working together as a team with the patient in the lead role. As the patient, only you have the unique experience of being you. You know your body and your healthcare needs better than anyone else, including your doctor. So if you ever feel like something is not right, start keeping a log. Speak up, advocate for yourself, and find a doctor who will listen. You are your greatest advocate, so help us be your advocates too. Thank you.
Thank you so much, Yasmin. All right, next up is a student who is our only first-year student here tonight. The other students are second-year students, and this student was chosen from among her peers to come here tonight. And after choosing her, I learned an interesting fact that sets her apart, I believe, from every other student I've ever brought here to Battle Creek, and that is that she hails from a lovely place called Battle Creek. Would you please give a warm welcome to Battle Creek's own Becca Longman.
It is true. I am from here. Hi, everyone. My name is Rebecca Longman, and I am a first-year medical student at MSUCOM. And today I'm going to be talking about emotional changes in dementia. So my goal today is to just kind of bring to light and acknowledge the emotional changes you might see in your loved one and reassure everyone that these changes are a normal part of the disease and in no way reflect the personality of your loved one, because in my personal experience, it was the most challenging part of watching someone go through the disease. Since there is no cure, dealing with these changes the best we can is imperative to giving good care and being compassionate for our loved ones. And there's a nice picture there of me and my family with my grandfather. And here's some more pictures of my grandfather, my grandpa Jim. He was diagnosed with Alzheimer's around 2014, and he passed away from it in 2018. That was during my years of high school, so it actually truly inspired me and my older brother as well to become physicians. So the first type of dementia I'm going to be talking about is Alzheimer's dementia, which is what my grandfather had. So I'm going to be touching on the biggest emotional change I personally saw in my grandfather, which is aggression. About 45% of people diagnosed with Alzheimer's disease will exhibit aggression at some point, but typically during the later stages of the disease course. And there's evidence to suggest that these aggressive changes, are genetic and can be linked to 6 different genes. And aggression can make it hard to deliver quality care to our family and our loved ones, and it has an emotional impact on everyone involved. So what can trigger this aggression? Stress, anxiety, depression, and threats, either real or imagined. And this is going to lead us to our next topic, which is psychosis in Alzheimer's dementia. There's 2 main types of psychosis we see in Alzheimer's dementia: delusions and hallucinations. We can define delusions as an incorrect belief or judgment of our reality, even when evidence is presented to the contrary. A personal example would be my grandfather believing that the woman he was seeing was cheating on him with another family member, which was definitely not true, but no evidence could convince him otherwise, and it caused rifts between him and this family member and their relationship. And we can also see hallucinations in dementia as well, and these can involve any of the 5 senses, but visual and auditory are the most common that we see in Alzheimer's dementia. Psychotic symptoms occur in up to 50% of people with Alzheimer's and suggest a more severe form of the disease. Delusions are far more common than hallucinations in Alzheimer's. And those affected by psychosis are also at risk for developing other adverse emotional symptoms such as aggression and agitation, which is what I talked about earlier. So, what are these changes in psychosis? What do they look like in the brain? So you have more rapid cognitive decline prior to your psychosis onset, or the beginning of psychosis. You have greater cortical synapse loss, reduced gray matter, reduced cerebral blood flow, reduced glucose metabolism, All of that to say that your brain is shrinking, it's not working as well, you can't think as well. So now we're going to look at a few changes in Lewy body dementia. The major one being hallucinations. As opposed to Alzheimer's, where delusions are far more common, we see hallucinations in Lewy body dementia, and there's a greater chance of having these hallucinations earlier in the disease course. In Lewy body dementia, there are much more pathological changes to this area in our brain called the lateral geniculate nucleus than in other forms of dementia, and that's located here in the side of your head. And it's in between where vision comes into your head, your eyes, and where it's delivered at the back of your head in the occipital lobe. So disruption in this pathway could somehow have implications in our visual pathway and cause hallucinations that we see in Lewy body dementia. The next thing I want to talk about is an interesting syndrome called Capgras syndrome that is commonly seen in Lewy body dementia. So this syndrome is the belief that someone close to you, typically a loved one or a caregiver, has been replaced by an identical double. Interestingly, this is one of the most common delusions in Lewy body dementia, with up to 17% of patients being affected. The underlying mechanism is still not well known, but somewhat similar to the hallucinations, we think that reduced blood flow in the visual pathway is implicated in some way, especially to the occipital lobe in the back of our heads. So there could be less communication between the front and the back of our brains, leading to a disconnect between what is seen and what is recognized by the patient. So next I'm going to show you a figure that demonstrates this, so just keep in mind that bright colors equal blood flow. So here we have the scan of a healthy patient. We're looking down at the top of someone's brain right now. So the red indicates lots of blood flow and the blue indicates less. And this is a healthy brain. And this is the brain of a patient with Capgras syndrome and Lewy body dementia. So you can see there's far less red and a lot more blue and dark colors there in the center, this is indicating less blood flow and could be the cause of Capgras syndrome. Now, the last thing I want to talk about is emotional changes affecting caregivers. This is a major personal topic for all of us, I'm sure. And I just want to say caregivers are heroes. Everyone in this room that is dealing with this knows this. Dementia does not only affect the patient, it affects everyone around the patient. So take however many million of people have dementia in the world and multiply that by all the people around them, everyone's affected by this. It's an extremely stressful and time-consuming job to be a caregiver, and not to mention it's quite expensive. And it doesn't get as much thanks as it deserves. It's not a glamorous job, but it is a very fulfilling one. And I just want to say I'm proud of everyone in here who's dealt with that and who is stepping up to be a caregiver. Major props. I saw my mom, she was my grandfather's caregiver, and she was there at all times of the night, drove all over to help him, and it was really hard to see her struggle with him struggling. So I just want to shout out everyone for being here. And as rates of dementia rise, there are going to be more and more people dealing with this. So it's good that we address it now because it's not going to be a stranger to anyone. So please be kind to yourself and seek out relationships that can help you cope with what is happening to your loved one. As I said before, it's not a disease that only affects the patient. It's unique in that way. So please talk with your family members, other caregivers. Being here today is a major step. And I also included a helpline for the American Alzheimer's Association that is open anytime, 24/7, for people who need help, caregivers who need help. And thank you all for being here today. Good job for being here. Thank you for being caregivers, and go Battle Creek.
I got to remember that when I give my talk. If it starts going badly, I'll be like, just go Battle Creek. Works every time. All right. Our final student for you this evening hails from Augrey, Michigan. Cassidy Benson, second-year medical student at MSU. Please welcome Cassidy.
Okay. He is tall, but so am I, so this is good. As he said, my name is Cassidy Bench. I'm a second-year medical student at Michigan State's College of Osteopathic Medicine. Today, I'm going to talk a little bit about that initial office visit that kind of addresses maybe a complaint like memory loss. So The inspiration for this talk came from a conversation I had with my grandmother last fall. Her youngest sister, my Aunt Karen, was going through the process of being diagnosed with dementia. And my grandma's was dealing with a lot of emotions, and she's not one to sit with emotions for long. And she kind of looked at me and she said, well, I guess this is maybe just part of getting older. I thought about that a while. Is dementia part of aging? There's a survey from 2019 that reports that 2 out of 3 people believe that it is. It's just a typical part of the aging process. I can see where it's coming from. Dementia is common and aging can be a risk factor, but the features of dementia are incredibly distinct from those of typical aging. And so I wanted to look at, where this is coming from and how this might impact people on their journey to a dementia diagnosis. I've seen in my own family, like stigma surrounding memory loss and just aging in general lead to a hesitancy to bring this up at the doctor's office. I think it's incredibly important to have a distinction between aging and some of the features seen with memory loss, because we can kind of eliminate some of the stigma surrounding it, hopefully leading to the opportunity for earlier diagnoses and the opportunity for earlier intervention. So let's take a look at what some of those differences are. Very generally speaking, aging can be referred to as cognitive slowing, whereas dementia is described as cognitive decline. What this might look like is that with aging, we have difficulty remembering the name of somebody that we just met, whereas dementia, we're starting to forget our own family members. With aging, it may take us longer to learn something new, but with dementia, we start losing skills that we maybe have had for decades. Now, this can look very similar in the clinic, and maybe you have symptoms that fit into either category. One of the clinical distinctions we use is that dementia symptoms start to interfere with your day-to-day life. So, the initial workup for a complaint such as memory loss is going to take a look at how your symptoms have been interfering with your daily life. Hopefully, it's open-ended question at the start. How have you been lately? This should be a good opportunity for you and your loved one to kind of express the symptoms you've been experiencing and what you're most concerned about regarding your health. Some further questions are going to take a look at 2 very important categories called ADLs and IADLs. At the top in green, we have the ADLs, or the activities of daily living. Now, these include showering, feeding, going to the bathroom, and getting dressed in the morning. These are functions that are essential to meeting our basic needs, whereas at the bottom are the IADLs, or the instrumental activities of daily living. These include driving, going grocery shopping, cooking our meals, or managing our finances. They give us a certain level of independence, but they're deemed less critical as far as meeting our basic needs. Addressing some of these activities not only ensures that these needs are being met for you, but they give us some insight into how your daily life is being interfered with. Now, the interview gives us a lot of information and a lot of good insight, but doctors really like tests, and so there are several that kind of give us an opportunity to look at how your brain is working. One of these is shown here on the right of the screen. It's an easy one-sided piece of paper that takes about 5 to 10 minutes and provides a numerical value that reflects how your brain is working. Now, this is not diagnostic of dementia in and of itself, but it provides good context, especially in an initial workup of where you're at. And one of the most valuable things it can provide is the opportunity to track cognitive functioning over time with repeated testing. So the initial workup, we talk about some symptoms, and we can start to correlate those symptoms with what areas of the brain may be contributing to the symptoms. So let's take a closer look at what I mean. The image at the top right of the screen is as if we're looking at the brain from the side. The area in red is the frontal lobe located at the front of your brain. As we move backwards, in orange is the parietal lobe. Behind that in yellow is the occipital lobe. At the side in green is the temporal lobe. And tucked underneath in blue is the cerebellum. Now, memory is one of the focal point symptoms that we see with dementia and aging. It's incredibly complex, and there are different types of memory loss that may indicate injury to different areas of the brain. One example of this is long-term memory. So difficulty making new memories or recalling things that happened a couple weeks ago, a month ago, may indicate injury to the hippocampus, which is an area at the side of our brain in the temporal lobe. A different way we use memory is with a phenomenon called muscle memory. So this is how we have the ability to do certain familiar tasks without having to think about them too much. Now, this is a coordinated effort through the motor cortex, which is at the back of the frontal lobe in red, and the cerebellum in blue. The motor cortex tells our muscles to move, and the cerebellum keeps them moving smoothly. Injury to this pathway may look like symptoms such as difficulty brushing your teeth, brushing your hair, tying your shoes, stuff that you've probably known how to do for a while and are now challenging. Another skill we have that involves multiple areas of the brain is visual recognition. So the ability to see starts with our eyes taking in whatever is happening in front of us and sending that signal to the occipital lobe in the back of the brain. This signal is then shared with a temporal lobe at the side of our brain, who tells us if we recognize this image as something or someone familiar. This explains why injury to this pathway might lead to a symptom such as difficulty recognizing somebody we know, even our loved ones. Another important skill we have in symptoms that we might see at an initial workup at the office visit is just communicating. So first, that's going to start with listening. The ability to hear comes from signal being transmitted through our ears to the temporal lobe, again, in the side of our brain. And that signal is shared with a different area in the temporal lobe that actually tells us if we can recognize that sound as a language that we comprehend. From there, our ability to maintain concentration and focus on, say, the conversation we're having with our physician reflects the ability of the very front of the frontal lobe. So injury to that area may look like inattentiveness. And then the ability to produce speech, so not to understand it, but to even form the words, also comes from a different area in the frontal lobe, located a little more on the side. So just from an initial workup and interview, we can gain an idea of some of the symptoms that a person may be experiencing, how it's impacting their life, and what areas of the brain may be contributing. From there, it's certainly not a one-day diagnosis to dementia. There are several steps that are in between, and some of them are on this slide. One of the important ones is screening for reversible causes of dementia, or rather cognitive decline. This is going to include stuff like screening for major depressive disorder, as this can often look a lot like dementia. Reviewing the medications that you or your loved one may be taking, as certain medications can interact and cause difficulty with the way our brain is working. And then certain labs and imaging that may indicate if something else is going on other than dementia, or may give more insight into the dementia itself. From there, we want to establish a very specific diagnosis. So not only to rule out, is this dementia or something else, but as Yasmin went over, what type of dementia we're looking at. This gives us the best opportunity to utilize the most appropriate interventions, hopefully early. From here, we want to make sure we're maintaining regular follow-up, not only to track the progression of maybe symptoms associated with dementia, but also to just monitor every aspect of health as you navigate this disease. Next, discuss referral options. There are several different factors to consider in dementia, as we spoke about before. So not only could you request to see a dementia specialist, but maybe you want to work with a nutritionist, occupational therapy, social worker, whoever it may be. And from there, find a supportive community. I think this group is obviously a clear example of that, but with dementia being as common as it is, you're certainly not alone in this, and walking through it with other people that understand what you're going through is probably the best way to handle it. Thank you for letting me come speak today. I appreciate your time.